Welcome, Maggie. Today we're diving into a crucial area of modern medicine with our session titled Beyond Comfort, Advanced Palliative Care Today. It's vital to understand how far this field has evolved, moving beyond just basic comfort to encompass truly advanced medical interventions.
Thank you, Thomas. I'm really looking forward to this. I've been keen to grasp the nuances of contemporary hospice and palliative care, especially how personalized approaches are integrated with these advanced medical strategies.
To begin our discussion on the evolution of hospice and palliative care, it's important to establish its formal recognition. Hospice and Palliative Medicine, or HPM, was officially recognized as a medical subspecialty by the American Board of Medical Specialties in 2006.
So, that formal recognition in 2006 marked a significant turning point for the field. What has been the impact of that recognition on its growth?
Precisely. That recognition was pivotal. Since then, the field has experienced substantial growth. By 2022, HPM had become the fifth largest medical subspecialty, indicating a rapid expansion and increased demand for its services.
That's a remarkable increase in just over a decade and a half. Does this growth mean there's a more diverse group of physicians entering the field now?
Yes, it does. The growth has indeed led to a more diverse group of dedicated physicians. Some now choose HPM as their primary specialty directly out of residency, while others integrate it into their practice mid-career, bringing varied experiences to the field.
So the evolution isn't just about formal recognition and size, but also about the professional pathways into HPM. Could you elaborate on how the roles of hospice medical directors and hospice physicians have evolved with this growth?
Certainly. The roles of hospice medical directors, or HMDs, and hospice physicians, HPs, have become increasingly complex. HMDs are now responsible for the entire medical component of hospice care, including supervising HPs and ensuring robust quality assurance and performance improvement.
So, beyond direct patient care, HMDs have significant administrative and oversight responsibilities. What specific documentation or program participation is required of them?
They must meticulously document hospice eligibility and relatedness for each patient. Furthermore, active participation in the hospice's Quality Assurance and Performance Improvement, or QAPI program, is a mandatory regulatory requirement.
That sounds like a comprehensive set of responsibilities. Does their role also extend to community engagement or education?
Absolutely. HMDs and HPs are increasingly involved in community education, outreach, and advocacy. They emphasize the interdisciplinary team model and person-centered care, which are foundational to modern hospice philosophy.
So the evolution includes a broader scope, from direct medical oversight to quality control and external advocacy. What about the regulatory and administrative burdens that have emerged with this evolution?
That's a critical point. The conditions of participation, or COPS, require every Medicare-certified hospice to have an HMD. This role now demands ensuring consistent, quality medical care 24/7 and managing fiscal responsibilities such as cost-effective pharmaceutical provision.
So HMDs are not only clinical leaders, but also have significant financial and ethical navigation responsibilities. How has the medical complexity of hospice care itself evolved?
The medical complexity has increased substantially. Hospices now manage complex symptom burdens with advanced interventions. This includes patient-controlled analgesia, or PCA, and non-invasive ventilation, which were less common in earlier hospice models.
Are there other advanced treatments that hospices are now supporting, even if they aren't strictly required by the Medicare hospice benefit?
Yes, some hospices now support advanced treatments like radiation therapy, transfusions, and even dialysis. While not mandated by the Medicare hospice benefit, these are offered to align with person-centered goals and manage complex conditions.
That's a significant shift, indicating a move towards more comprehensive medical support within hospice. What challenges have arisen from this increased medical complexity and patient demand?
The increased complexity has led to greater physician involvement. There's also a growth in direct requests from patients and families for hospice services, which necessitates astute prognostication skills from HMDs and HPs. Additionally, careful deprescribing and person-centered medication management are now crucial.
So the evolution has brought about a need for more specialized clinical skills, particularly in prognostication and medication management. To summarize, the field has evolved from formal recognition in 2006 to becoming a major subspecialty, with HMDs and HPs taking on increasingly complex clinical, administrative, and ethical roles, and incorporating advanced medical interventions. Is that an accurate overview?
That is an excellent summary, Maggie. It captures the key aspects of the evolution of hospice and palliative medicine, highlighting its growth, the expanding roles of its practitioners, and the increasing sophistication of the care provided. That is an excellent summary, Maggie. It captures the key aspects of the evolution of hospice and palliative medicine, highlighting its growth, the expanding roles of its practitioners, and the increasing sophistication of the care provided. Now, let's delve deeper into the rationale behind these advanced medical interventions.
Understood, Thomas. So, beyond just managing symptoms, what specific patient-centered goals drive the decision to implement advanced medical interventions in hospice care?
The primary driver is enhancing the patient's quality of life and aligning care with their expressed wishes. This often involves balancing potential life prolongation with symptom burden and overall comfort. Interventions like radiation therapy, for instance, might be used to alleviate pain from bone metastases, directly improving comfort.
So the focus is always on the patient's comfort and their individual goals, even when considering treatments that might seem aggressive. How does accurate prognostication factor into these decisions?
Prognostication is critical. HMDs and HPs must accurately assess the patient's disease trajectory and remaining life expectancy. This informs whether an advanced intervention is truly beneficial within the context of their limited time, ensuring it aligns with their goals rather than causing undue burden.
It sounds like a delicate balance. What specific skills do hospice medical directors and hospice physicians need to make these complex decisions about advanced interventions?
They require strong communication skills to elicit patient values, ethical reasoning to navigate difficult choices, and a deep understanding of various disease processes. Furthermore, they must be adept at assessing the potential benefits versus the burdens of any proposed intervention.
Given a complexity, what ethical dilemmas commonly arise when considering advanced interventions within a hospice setting?
Common dilemmas include managing patient and family expectations for aggressive treatment, ensuring interventions do not prolong suffering, and respecting patient autonomy when choices conflict with medical recommendations. There is also the ethical consideration of resource allocation.
That makes sense. How do regulatory requirements, such as the Medicare conditions of participation, influence the use and oversight of these advanced medical interventions?
While the Medicare hospice benefit does not mandate specific advanced treatments like dialysis, the COPs require comprehensive oversight of all medical care provided. This means HMDs must ensure that any intervention, whether common or advanced, is clinically appropriate, safe, and aligns with the patient's plan of care.
So, even if not explicitly required, the quality and appropriateness of these interventions are still under regulatory scrutiny. How does the Quality Assurance and Performance Improvement Program, or QCAPI, apply to advanced interventions?
QAP programs are essential for monitoring the effectiveness and safety of all care, including advanced interventions. They ensure that these treatments are delivered according to best practices, contribute positively to patient outcomes, and are continuously evaluated for improvement.
So QPAP helps maintain high standards for these complex treatments. How does interdisciplinary collaboration factor into managing these advanced interventions effectively?
Collaboration is paramount. The HMD works closely with the entire interdisciplinary team, including nurses, social workers, chaplains, and other specialists. This ensures a unified approach to care, where each team member contributes to the planning and delivery of complex interventions.
Does this collaboration extend beyond the immediate hospice team to external healthcare providers?
Absolutely. Engaging with community healthcare providers and organizations is crucial. This ensures continuity of care, especially when coordinating specialized treatments or transitioning patients, and helps align patient care goals across different settings.
Could you provide an example of how this external collaboration might look for a patient receiving, say, transfusions in hospice?
Certainly. The HMD would coordinate with the patient's hematologist to determine the necessity and frequency of transfusions. The hospice nursing staff would administer the treatment, and social work might assist with transportation or logistical support, all while ensuring the intervention aligns with the patient's comfort and goals.
That clarifies the practical application. So, to summarize, advanced medical interventions in palliative care are driven by patient-centered goals, require precise prognostication and ethical navigation, and are managed through strict regulatory oversight, continuous quality improvement, and extensive interdisciplinary collaboration, both internal and external. Is that an accurate overview?
That is an accurate and comprehensive summary, Maggie. It encapsulates the multifaceted approach required for advanced medical interventions in contemporary hospice and palliative care, emphasizing the integration of clinical, ethical, and administrative considerations. Following our discussion on the evolution of hospice and palliative medicine, let's now focus on the specific regulatory and administrative responsibilities of hospice medical directors and hospice physicians. Beyond the general oversight we've touched upon, HMDs are directly involved in the certification and recertification processes for patients.
So, Thomas, what exactly does their involvement in certification and recertification entail? Is it primarily about signing off on documents, or is there a deeper clinical assessment required?
It's a deeper clinical assessment. HMDs must personally attest to the patient's hospice eligibility, confirming that the prognosis aligns with the Medicare hospice benefit criteria. This involves reviewing medical records, conducting patient assessments, and ensuring the patient's condition warrants hospice care for the initial certification and subsequent recertifications.
That clarifies their direct clinical responsibility in the process. You also mentioned fiscal responsibilities earlier. Could you elaborate on how HMDs ensure pharmaceuticals are both clinically appropriate and cost-effective?
Certainly. HMDs are tasked with overseeing the provision of all pharmaceuticals. This means evaluating medication regimens for clinical efficacy and appropriateness for the patient's condition and goals, while also considering cost-effectiveness. They must balance optimal symptom management with responsible resource utilization, often through formulary management and deprescribing initiatives.
So it's a dual role of clinical judgment and financial stewardship regarding medications. How do HMDs and HPs specifically integrate into the interdisciplinary team beyond just advocating for the model?
They are integral members, not just advocates. HMDs and HPs actively participate in IDT meetings, contributing their medical expertise to care planning. They collaborate with nurses, social workers, chaplains, and other specialists to ensure a holistic and coordinated approach to patient care, aligning medical interventions with the patient's psychosocial and spiritual needs.
That makes sense. So they're not just supervising, but actively contributing to the team's collective decision-making. To summarize this part, HMDs are crucial for patient certification and recertification through clinical assessment. They manage pharmaceutical provision for both clinical appropriateness and cost-effectiveness, and they are active, collaborative members of the interdisciplinary team. Is that correct?
That is an accurate summary, Maggie. Now, let's transition to the ethical complexities and challenges faced by HMDs and HPs, particularly concerning both clinical and business practices.
Understood. What are some of the challenging medical ethical issues they commonly encounter in their clinical practice?
They frequently navigate dilemmas, such as managing patient and family expectations for aggressive treatments that may not align with hospice philosophy, ensuring interventions do not inadvertently prolong suffering, and respecting patient autonomy when choices conflict with medical recommendations. Deciding when to initiate or withdraw life-sustaining treatments within a hospice context is also a common ethical challenge.
Those sound like very sensitive situations. Are there also business-related ethical dilemmas that HMDs must address?
Yes, absolutely. Business-related dilemmas can include balancing financial sustainability with patient care needs, ensuring equitable access to services, and avoiding conflicts of interest. They must uphold ethical principles in all business decisions, ensuring that financial considerations do not compromise the quality or integrity of patient care.
So they're balancing patient well-being with the operational realities of the hospice. Given these demanding clinical and administrative duties, what are the implications for burnout and compassion fatigue among HMDs and HPs?
The demanding nature of their roles makes HMDs and HPs highly susceptible to burnout and compassion fatigue. They are constantly exposed to suffering and loss, coupled with significant administrative burdens. This can lead to emotional exhaustion, depersonalization, and a reduced sense of personal accomplishment.
That's a serious concern. What strategies are crucial for recognizing and addressing these issues?
Self-awareness and reflection are paramount. HMDs and HPs must be attuned to the early signs of burnout in themselves and their colleagues. Implementing support systems such as peer support groups, mentorship, and access to mental health resources is crucial. Organizations also have a responsibility to foster a culture that prioritizes well-being and provides adequate staffing.
So, ethical navigation extends to both clinical and business aspects, and there's a significant risk of burnout that requires self-awareness and organizational support. That covers the challenge as well. Now, let's move to their educational and leadership roles.
Excellent. HMDs and HPs play vital roles in education. They are often involved in medical and nursing educational programs, providing clinical rotations for medical students and residents, and offering mentorship to aspiring palliative care professionals. They also participate in conferences and workshops, disseminating knowledge and best practices.
So, they're actively shaping the next generation of healthcare providers. What about their leadership responsibilities within the hospice organization itself?
Leadership skills are essential for HMDs. They are responsible for leading physicians and advanced practice providers, ensuring consistent, high-quality medical care across the organization. This involves setting clinical standards, fostering a collaborative environment, and guiding the medical team through complex cases and policy changes.
So they're educators and clinical leaders, ensuring quality and guiding their teams. To summarize our entire discussion on the role of hospice medical directors and physicians, they have evolved into complex roles encompassing rigorous regulatory and administrative duties, navigating profound ethical dilemmas in both clinical and business contexts, managing the risk of burnout, and serving as crucial educators and leaders within the field. Is that a comprehensive overview?
That is an exceptionally comprehensive and accurate overview, Maggie. It effectively synthesizes the multifaceted responsibilities and challenges inherent in the contemporary roles of hospice medical directors and hospice physicians. Following our comprehensive overview of the roles and responsibilities, let's now shift our focus to the contemporary challenges and opportunities within hospice and palliative care. The field, while growing, faces significant complexities.
Understood, Thomas. What are the primary challenges that hospice medical directors and hospice physicians are encountering today?
One significant challenge is the increasing medical and ethical complexity of cases. HMDs and HPs must navigate intricate medical issues, often requiring advanced palliative interventions, and apply systematic, unbiased ethical principles to their decision-making.
Could you provide examples of these advanced palliative interventions that contribute to this complexity?
Certainly, we are seeing more common use of interventions like patient-controlled analgesia for pain management and non-invasive ventilation for respiratory support. These require specialized knowledge and careful oversight within the hospice setting.
Beyond the clinical complexity, are there financial challenges that HMDs must address?
Yes, financial stewardship is crucial. HMDs are responsible for ensuring that pharmaceuticals provided are not only clinically appropriate for the patient's condition and goals, but also cost-effective. This involves careful formulary management and deprescribing initiatives.
So they balance optimal patient care with responsible resource utilization. What about the human toll on these professionals?
That leads to another critical challenge: burnout and compassion fatigue. The demanding nature of both clinical and administrative duties, coupled with constant exposure to suffering and loss, makes HMDs and HPs highly susceptible to emotional exhaustion.
What strategies are essential for recognizing and mitigating burnout and compassion fatigue in this field?
Self-awareness and reflection are paramount for individuals to recognize early signs. Organizations must also implement robust support systems, including peer support groups, mentorship, and access to mental health resources to foster a culture of well-being.
So, the challenges include complex medical and ethical decisions, financial stewardship, and the significant risk of burnout. Now, let's transition to the opportunities within contemporary hospice care.
Excellent. Despite these challenges, the growth in hospice care presents significant opportunities. In 2022, there were 5,890 Medicare-certified hospices, enrolling 1.72 million beneficiaries, indicating increased physician involvement and demand.
That's substantial growth. Does this mean more patients are accessing hospice care earlier in their end-of-life journey?
Precisely. More patients are indeed accessing hospice care earlier. This provides a greater opportunity for HMDs and HPs to serve more families, offering comprehensive support for a longer duration, which can significantly improve quality of life.
Beyond direct patient care, what opportunities exist for HMDs and HPs to engage with the broader healthcare community?
They have significant opportunities for community engagement. This includes educating colleagues about hospice and palliative care, collaborating with medical leaders from partnering organizations, and serving as vital resources for community healthcare providers.
And what about educational opportunities within academic settings?
HMDs and HPs are encouraged to partner with medical and nursing educational programs. This involves offering clinical rotations for students and residents, participating in conferences, and contributing to the development of future palliative care professionals.
So they play a crucial role in shaping future healthcare. To summarize, the opportunities include leveraging the growth in hospice care to serve more patients earlier, engaging with the community through education and collaboration, and partnering with educational institutions to train the next generation. Is that accurate?
That is an accurate and comprehensive summary, Maggie. It highlights how HMDs and HPs can expand their impact through direct patient care, community outreach, and professional education.
Thank you, Thomas. This clarifies both the demanding aspects and the promising avenues for growth and influence within contemporary hospice and palliative care.
All right, Maggie. To bring our session to a close, we've truly explored the depth of advanced palliative care today. We started with the field's formal recognition and remarkable growth, then delved into the multifaceted roles of hospice medical directors and hospice physicians, covering their clinical, administrative, and ethical responsibilities. We also examined the rationale behind advanced medical interventions and the contemporary challenges and opportunities that define this vital area of medicine. For your studies, I'd recommend creating a concept map that links the regulatory requirements to the specific responsibilities of HMDs and HPs. Also, try to articulate the why behind each advanced intervention, always connecting it back to patient-centered goals and quality of life. This will help you apply the knowledge, not just memorize it.
That's excellent advice, Maggie. The concept map idea is particularly helpful for visualizing the interconnectedness of their roles. I'll definitely focus on the patient-centered rationale for interventions and review the ethical dilemmas we discussed, as those seem particularly nuanced.
Perfect. Next time, we'll shift our focus to the future of palliative care, exploring emerging trends, technological advancements,